and augmentation of flow test, because there is a possibility of the clot getting dislodged and leading to pulmonary embolism. As I mentioned, today duplex ultrasound is the gold standard for this, but we may not be able to see calf vein thrombosis and iliac veins very clearly using duplex ultrasound. And so that's where MRI or CT venography is useful. Today, we rarely perform traditional venography or plethysmography. This is an old, sorry for that. This is an old photograph of venogram done way back in 1996, I think. And you can see that there is no visualization of the femoral vein in the thigh, and there is a loose tail of the clot that is seen in the femoral vein just below the non-visualized femoral. So, I mean, of course, today we probably will never be able to see this particular what is happening. Okay, we will not be able to see this venogram. There are certain sequel of deep vein thrombosis, maybe pulmonary embolism, as you can see in this CT plate, which can lead to, of course, it can lead to death, but it can lead to chronic pulmonary hypertension. Post-thrombotic syndrome, as we were talking about, one of the causes of venous ulcer could be post-thrombotic syndrome. And this is a vein that you can see which is partially recanalized following a thrombosis. And this is very classical lipodermatosclerosis with hyperpigmentation that one can see in post-thrombotic syndrome. Partially recanalized vein with its irregular walls is an invitation for recurrent DVT. And so it is essential that we treat the patients appropriately. To start with initial investigations after confirmation of DVT diagnosis, the baseline investigations are pretty simple. Hemoglobin, platelet count is mandatory, so is creatinine, because dose of some of the medications that we will be using depends on creatinine clearance and renal function. We'll also do urine analysis and a baseline INR and APTT for monitoring our treatment protocol. Subsequently, if we are using unfractionated heparin, we have to do APTT every 6 hourly. For low molecular weight heparin therapy, which is the preferred treatment now, APTT is not essential. Platelet count daily is essential when patient is on any type of heparin, as there is always a possibility of development of heparin-induced thrombocytopenia. While PT and INR is required every day when patient is on initial period, at least when patient is on vitamin K antagonist. DVT management today is divided into 3 time zones. First is initial management for 5 to 21 days. And the agents that one would be using during this period could be heparins, preferably low molecular weight heparin, or in patients who have low platelet count, less than 1 lakh, or have developed HIT, or that is heparin-induced thrombocytopenia, fondaparinux is the choice. And this then followed by NOACs, that is novel oral anticoagulants, or vitamin K antagonists. The primary treatment lasts for 3 to 6 months, depending on the factors that I have mentioned later, and most often will include treatment with either VKA or NOAC. Secondary prevention is beyond first 3 to 6 months period and may include NOAC, VKA, and newer addition, aspirin. What is the duration of treatment for these patients? When patient has provoked DVT and there is a transient risk factor, such as long travel, which is a transient risk factor, It may be surgery, which is a transient risk factor. It may be injury, which may be a transient risk factor. In these factors, the treatment duration should be 3 months. While if the patient has unprovoked DVT or PE or has associated chronic risk factor, such as malignancy or hypercoagulable state, then the first treatment is for 6 months and then needs to be continued. A nice way of saying that is long term, but actually it is lifelong. For proximal DVT is defined as DVT above the vein segment. Above means above the confluence of the 3 veins in the leg, formation of the popliteal vein upwards. The recommendation of ACCP is that initial 5 days at least of heparin or fondaparinux, along with starting of warfarin as vitamin K antagonist. Preferred is of course low molecular weight heparin or fondaparinux and not unfractionated heparin. Oral anticoagulant must be started on the same day as heparin or fondaparinux, and quite often we observe that there is a delay in starting the oral anticoagulant, which is not necessary. If patient comes within first 5 days of developing iliac vein thrombosis with massive leg edema, then one may consider performing PCDT or CDT, and I'll come to the details of this later on. PCDT means pharmacomechanical catheter-directed thrombolysis and thrombectomy, and CDT means catheter-directed thrombolysis. We'll come to its details a little later. Though I did mention that unfractionated heparin is not the preferred anticoagulation in the initial period, not only initial period, not preferred today, but we may have some parts of India where low molecular weight heparin may not be available so easily. And so I have given here the dosage schedule of unfractionated heparin also. Again, subcutaneous injection of unfractionated heparin is not the preferred route of administration. Continuous IV infusion is the preferred route. And initial bolus of 80 units per kg is to be given intravenously, followed by 18 units per kg per hour infusion of unfractionated heparin. APTT is to be performed every 6 hourly and should be maintained between 1.5 to 2.5 times of control. If necessary, the dose needs to be adjusted so as to achieve the desired APTT levels. This infusion should continue for a minimum 5 days, and as I mentioned earlier, we should be starting the oral anticoagulant along with it when we are using warfarin for long-term anticoagulation. If we are doing initial management with low molecular weight heparin, and that is what is recommended, I have provided here the dosage schedule of enoxaparin. I personally feel that it is better to be completely knowledgeable about at least one or at the most 2 molecules of low molecular weight heparin. The dosage schedule of each molecule varies, and interchangeability between different molecules is not really advisable. So please try and remember schedule of at least 1 molecule or 2, just in case you don't find the first one. Enoxaparin schedule is if the patient's weight is less than 100 kilograms and there is no associated malignancy or renal failure, then the dose recommended is 150 units per kg once a day. When the dose is less than 1 ml, once a day dose is good enough, and that's what is recommended. If patient has associated chronic renal failure, the dose comes down to 100 units per kg once a day. But if the weight is more than 100 kgs, or if patient has associated malignancy, then the recommended dose is 100 units per kg twice daily. That means we give increased dose with associated malignancy, and of course, it is weight related as well. Unmonitored LMWH therapy is possible, but these are the conditions where one should not give unmonitored low molecular weight heparin therapy. That is age less than 18 years, association with chronic renal or hepatic disease, previous history of heparin-induced thrombocytopenia, severe hypertension, morbid obesity, low platelet count, patient who has undergone surgery, has recently bled, then you should not be treating the patient at home, but patient needs hospitalization. Fondaparinux is an excellent anticoagulant and is an very, very important alternative that one should use when either the patient has developed heparin-induced thrombocytopenia or patient has low platelet count. This is a synthetic pentasaccharide and it's an indirect factor 10A inhibitor. It does not inhibit thrombin. The dosage schedule is very, very simple as I have given it here. Less than 50 kgs, 5 milligrams subcutaneously once a day. Between 50 and 100 kgs, 7.5 milligrams. And more than 100 kgs, 10 milligrams subcutaneously once a day. And the duration of therapy is 5 to 9 days, as we would be starting the vitamin K antagonist therapy along with the first day of fondaparinux. So here comes warfarin. Warfarin dosage has undergone the complete circle. So when I was in medical college, we were told that there should be a loading dose. Then came a time when we were told that there should be no loading dose. Now it has changed again and we are back to some kind of loading dose. So 10 milligrams of warfarin on day 1, 10 milligrams of warfarin on day 2, and day 3 we'll be giving 5 milligrams of warfarin. By this time, we will have 3 INR PT reports, and then accordingly, the dose of INR is to be modified to achieve desired INR of 2.5 with the range of 2 to 3. INR is done daily till it reaches the desired range for 3 consecutive days. And after that, we can fix the dose and then keep doing INR twice weekly for 2 weeks and later on even with less frequency. If we have reached the targeted INR, then it can be rechecked as infrequently as once every 3 months also. That is a grade 2B recommendation. INR fluctuation of plus or minus 0.5 is acceptable and we should not change the dose. Only we should repeat the INR in 1 or 2 weeks and then only decide whether any change is required. Vitamin K should not be administered to these patients. And coming to adverse effects, because that is something that we should be worried about. I think anticoagulant prescription is probably the worst prescription or the most dangerous prescription that any surgeon would ever be writing, because it is associated with multiple complications or possibility of complications, and they can be fatal as well. With vitamin K antagonist, the adverse effects are very likely. They depend on the timing of the dose in relation to food intake, concomitant medications, and patients must be explained very clearly that there should be a gap of at least 1.5 to 2 hours between food and the warfarin tablet on either side of warfarin tablet. We should give instructions as to which food is to be avoided and which medications, particularly non-steroidal anti-inflammatory agents, should be avoided when patient is on warfarin. If patient's INR is up to 10 and there is no bleeding, then we should just withhold vitamin K antagonist and not give vitamin K or any other plasma product. But if it is greater than 10 without evidence of bleeding, then withdraw VKA and give oral vitamin K. Associated with major bleeding, which is really worrisome, at any dose, then we need to reverse the coagulopathy with 4-factor prothrombin complex and not fresh frozen plasma. Vitamin K is also to be given intravenously as slow injection to these patients. What is this 4-factor prothrombin complex? It contains vitamin K dependent coagulation factors, that is factor 2, factor 7, factor 9, and factor 10. It also contains protein C and S. And the source obviously is pooled human plasma. It gives rapid reversal of VKA effect, and the dose is dependent on INR and weight. It does have risk of thromboembolic event associated with its administration. It's available as K-Centra. Patient counseling is essential with all anticoagulants. We must explain to the patient what exactly is the aim of this treatment and what are the possible complications and hemorrhagic complications. We should tell the patient that non-steroidal anti-inflammatory drugs should not be taken. There is interaction with antituberculous drugs and anti-epileptics, and this is true with practically all anticoagulants, including NOACs. Patient education about hemorrhage, as I mentioned, and it's important that patient is given an emergency contact information point so that in case of any adverse event, the patient must be able to contact you so that treatment can be started immediately. So summarizing the primary treatment and secondary prevention with VKA therapy, there should be overlap between heparin or fondaparinux and warfarin for at least 4 days. For transient risk factor, we give vitamin K antagonists for 3 months. Idiopathic first event 6 months, but recurrent DVT or ongoing risk, long-term or lifelong. Symptomatic isolated calf vein thrombosis, it should be 6 weeks to 12 weeks of treatment. Just coming shortly to NOACs, Dr. Rajesh, I'll be finishing in 2-3 minutes. These are direct acting agents, newly available. The first one to become available was rivaroxaban, direct factor 10A inhibitor. Another direct factor 10A inhibitor is apixaban, and direct thrombin inhibitor is dabigatran. What is the difference between this and vitamin K antagonists? It requires no monitoring. The effect of food is not there, but dabigatran does have interaction with alcohol. So it's not that everything is very simple. These drugs are short acting. The action lasts for 12 hours. So the patient should not be missing the dose. It is to be taken twice daily. If patient misses a dose, he should take it immediately as soon as he or she remembers it. All these NOACs are expensive. The antidotes were not available till recently, but now they are available and they are expensive too. Just in short, rivaroxaban prevents conversion of prothrombin to thrombin because of inhibition of factor 10A. The dose is 15 milligrams twice a day, that is 12 hourly, for first 21 days. And then from 22nd day, we change it to 1 tablet of 20 milligrams once a day with food. The dose may have to be adjusted depending on renal and hepatic function, so that needs to be monitored. The reversal agent name is andexanet alpha, expensive. The second factor 10A inhibitor is apixaban. The dosage schedule is as given here. It is generally started 5 days after heparin, even rivaroxaban. It will take some time for the patients to procure these medicines due to the cost as well as availability. Dose adjustment of apixaban needs to be done with advanced age, low weight, high creatinine, hepatic dysfunction, drug interaction, and reversal agent is same as rivaroxaban. Dabigatran is direct thrombin inhibitor, and again it is started after 5 days of parenteral anticoagulation. It comes in different strengths, 75, 110, 150 milligrams twice daily orally. The dose is adjusted depending on the weight, creatinine in clearance, and it does interact with alcohol. The reversal agent is idarucizumab. Again, expensive. Secondary prevention is to be done in patients who develop recurrent DVT or have chronic risk factor or hereditary thrombophilic state. Male patients who continue to have high D-dimer levels 1 month after withdrawal of initial anticoagulant treatment are also the candidates for secondary prevention, that is lifelong anticoagulation treatment. Here comes the role of aspirin. Some patients may not be willing to continue with anticoagulation, or they may not be able to afford anticoagulation, or it may not be available. These are the patients who should be on aspirin. There is evidence that aspirin reduces the recurrence risk by 1/3. Just one slide about endovenous intervention. As I mentioned earlier, iliac vein thrombosis, early presentation, and massive leg edema is the indication. But most important indication is that it should be done in a high volume center with an experienced person. Then the mortality is comparable to treatment with anticoagulation. Otherwise, the charges are higher, hospital stay is longer, bleeding episode possibility is much higher, and recurrence or PTS is unknown. Along with this, supportive therapy must be continued, limb elevation above heart level. These patients with DVT need not and should not be immobilized. In fact, they should be encouraged to walk and encouraged to do ankle and calf exercises, because stasis is one factor which leads to DVT. So it is absolutely illogical to keep these patients immobilized. Compression stockings are advised after edema reduction, and patients in whom edema or pain persists, their stocking use also needs to be continued. Some observations about DVT management from data collected by us. Subtherapeutic dose of heparin, incorrect route of heparin, LMWH given intramuscularly, dangerous. Inadequate duration of heparin. Heparin should be given, or fondaparinux should be given for at least a period of 5 days, ideally till you reach adequate INR if you are using vitamin K antagonist. Suboptimal oral anticoagulation is again one reason for inappropriate management of DVT. Inadequate monitoring happens if INR is not done regularly as advised. Repeated Doppler ultrasounds every 7 days, every 1 month are unnecessary, and neither is D-dimer estimation is required. So this is not necessary at all. Neglect of supportive care, no use of stockings is another factor that has been observed very commonly. What is most important is patient must be adequately educated and counseled about the use of anticoagulants and the need for it for his well-being. Thank you very much.
Yeah. Thank you, Gore Madam.
Thank you.
Any questions? You can directly put the questions in the chat box. Madam will answer them.
Okay.
Shall we go back to Dr. Paresh Pai?
Yeah.
Continue his
Are
lecture.
you still able to see my presentation? No. Okay. Thank you.
No, madam. Yeah.
Okay. Thank you.
Can you hear me now?
Yeah. Yes, we can hear you.
Yeah. Okay. This is the slide at which I got stuck. So generally for getting the wounds to heal, we use a multi-layer bandage system. It's either available as Profor from Smith & Nephew, or we use Velfor Kit A by Dutt Medi Products. It basically consists of 4 layers. The inner one, layer 1 is cotton wool. The layer 2 is a simple bandage, cotton bandage. The layer 3 is an elasticated crepe. And the layer 4 is a adhesive, the short stretch bandage. Now, it is very important that this is applied properly after you do the dressing. Should not be applied like this. So the skill of the therapist is extremely important, and you have to be particularly careful, especially in people with a champagne bottle leg, because the bandage tends to slip down. And when it does slip down, you get lots of folds in this, and the edges become quite sharp and cause ulcers or wounds by themselves. Using the figure of 8 gives you adequate pressure so that even when patients stand, the pressure is quite high and takes care of the venous insufficiency, even if it includes deep venous insufficiency. So this is the way it should be applied, and this is what it should look like at the end of it. You have to be particularly careful, especially in thin, lean individuals where there's not much of tissue around the ankle, because there's a tendency for injury of the skin and the subcutaneous tissue, and sometimes a tendon may get exposed if it made too tight. Now, if patients are not able to come on a regular basis, you have an option of using the ulcer stockings. So one such one is an Ulcer-X by Sigvaris, where you do the dressing, and then it's a system of 2 stockings. This one shows you that there is one inner layer, which is kind of a closed toe, and the other one is the outer layer. Now, the inner layer is understocking that exerts a mean pressure of at rest of about 18 millimeters of mercury at the ankle, and it's kept on for 24 hours. It should be removed at the time of having a bath and when the dressing is done. So generally it comes with 2 of these, so you can wash one, use one. The friction factor is significantly low to reduce the difficulties of the donning process. And not only that, the outer layer stocking, the second stocking, this is the Sigvaris traditional stocking, is put on over the understocking during the day. And the difficulties of wearing this are significantly reduced because of the smoothness of the first layer. This is removed at night. The ankle pressure acting with both stockings in place is about 40 millimeters of mercury at the ankle. So this also works well. The only problem is that the ulcers are, the dressing is unmonitored, and sometimes there could be issues. Now, if you have patients with high volume discharge, what I do is I combine this with the vac dressing, and what that does is that gets rid of all the fluid and speeds up the wound healing quite well. This is one such patient which I treated, had multiple ulcers. You can see that a lot of them have healed, but here you can see there are 3 ulcers here. So what I've done is I've treated them with Plermin gel, followed by a collagen which has been put there. This is covered by a Bactigra, on which I put isolated islands of the vac dressing, and then we put another layer of the adhesive which connects all these isolated areas, so that one dressing itself, one suction pad will take care of all the areas which are to be treated. And this works out very well. Now, when you're treating these ulcers and after you get these wounds to heal or before you start treating it, it's very important that we categorize the limb clinically as well as with venous Doppler. Generally, I tend to do the venous Doppler after the ulcer heals, because otherwise you find that this report is usually incomplete and it tends to mislead you. We also do MR venogram or IVUS, especially if there is presence of pain on standing. This can be either in the calf or in the thigh area. One limb is larger than the other, generally indicating, like Madam said, post-thrombotic limbs. And there is recurrence of treated perforators. So these are the patients where you start suspecting that there is problem higher up. So it's important that we correlate the etiology. Is it reflux alone, or is it reflux with obstruction? Because if you have both present, then it's important that we treat the obstruction first, and then the reflux may either get sorted out by itself, or you may have to take care of that. So you categorize the limb clinically. This is one such individual where you can see that he is obese. You can see that there is a kind of champagne bottle type of look. You can see the scarred area there, which has healed. And those crosses that you're seeing are defects in the fascia that you feel on palpation when you press against that area. So when you look at the venous Doppler, Dr. Shekhar has already said, look at the SFJ, the SPJ, the perforators, as well as the deep venous insufficiency. And here you can see that you've measured the size. So this is a patient who has got a size of 5.1 millimeters. So it's significant and it's located very close to the ulcer. So we have already discussed when to do the MR venogram or the IVUS. So this is the kind of images you see. I will talk about this a little bit more in detail, where this is a case of Thurner syndrome. And my friend Dr. Shekhar has shared his IVUS images with me. And you can see the difference in size. That's the size of the IVC. And as it comes down, you can see the IVC, the iliac, left iliac vein is getting compressed. Size is narrower. And as you come down, there is a second compression at the level of the external iliac vein. So if you have compression of the iliac vein, suspect that there is a May-Thurner syndrome. And this is usually treated with venoplasty and stenting. So this is the image where you can see the limb is like this. You can see that there is redness, there is congestion. The cross indicates an incompetent perforator. And when you do the reconstituted images, you can see that there is kind of a filling defect or a flattening of the vein, as a result of which you can't see any flow there. And when you see the transverse cuts, you can see that the vein is clearly getting indented between the vertebra and the crossing right iliac artery. So what do we do for these cases? We use a balloon where you use either a 14 mm into 40 millimeter balloon. And you can see that when you inflate the balloon, there's a waist. And then once the waist is removed, then you go ahead and stent it and then do a post-dilatation. Now, it is important that this is a very painful procedure and can't be done under local anesthesia. So generally, we tend to give a short GA, especially when we are inflating the balloon. You also have situation where you have a post-thrombotic syndrome, where you can either do a venoplasty and stenting or a venous bypass. This is one such patient. This was a medical rep working in Aventis. Now, this is a gentleman who had recurrent ulcers. You can see the scars of the ulcers. You can see the lipodermatosclerosis at the lower end. And you can see that it's early champagne bottle kind of thing. The scarring has less. And this gentleman used to keep coming, and he's been running from pillar to post. About 10 years ago, I did this procedure. What we did was we did a CT venogram, not an MR venogram at that stage. And basically here you can see that he had narrowing of the iliac veins. He had a duplicated IVC. So the IVC is narrow on both sides. And he had narrowing of the left common iliac vein. The left external iliac vein you can see is of good size. The right common iliac vein was also narrowed. And here you can see the pathology. And here we ended up putting 5 stents. To date, he comes regularly, follows up, and he's doing really well. It was fortunate that he worked for this company, multinational company, so they paid for all the stents, because these stents can cost from 60,000 rupees to 1 lakh each. So it does pack a budget for these type of cases. Now, important, Dr. Shekhar has already spoken about superficial venous incompetence. So I'll just quickly go through. Conservative management involves limb elevation, class 2 graduated compression stockings, exercises, venous tonics, sclerotherapy, and surgical treatment. Again, like he's already said, compression is very important, and it's graduated compression is the word. You get stockings which are like these, and really you'll find that these absolutely have no purpose, and especially those by Visco, which have a hole at the heel area, are the worst, because they are tight up and they are loose down and they create more problems. So using class 2 compression stocking works and gives good results. So this again, Dr. Shekhar has spoken about. I'll just touch upon a little bit more about perforator incompetence, because typically you see patients with either acute or chronic lipodermatosclerosis in the first 2 pictures, or you have the champagne bottle in the second picture, or the ulcers which are there, and these are pretty nasty. And initially we used to do open surgery where the surgery itself would cause wound. Then we started doing SEP, subfacial endoscopic perforator surgery. And now we have moved to sclerotherapy, foam sclerotherapy, or laser. So this is one such patient where I did foam sclerotherapy in the clinic. You can see the needle there, and that's injecting. And what is important is you use the transducer to give pressure on the system so that when you're injecting, very little or absolutely nothing gets into the deep system, and most of it refluxes into the superficial system. This is another patient, same thing we have done. You can see that there's hardly anything going in. And if the vein is very big, then we use the laser. Here you can see the needle going in. I use a gelco. The needle is removed, and through the gelco, then I put in the laser fiber, and then I fire it. Here you can see that being fired in the deep part. And as you come out, you can see it being fired in the superficial part. Complications of ultrasound-guided foam sclerotherapy. It can cause deep vein thrombosis if you're not careful. And what is important is when you do the sclerotherapy, also do the rapid ankle movements and pumping of the calf so that what little escapes into the deep system gets washed out very quickly. So friends, what I've tried to do is give a new look to an old problem. So we have a choice of continuing with old habits, or if we want to improve our results, we need to move with time. We need to embrace new technology, and we need to use every option that is available to us. All of this needs a lot of dedication and patience, but always aim high and play safe. Thank you.
Thank you very much, Paresh. Any questions?
We have Dr. Ajay Khanna who's logged in as an
Madam, there is a lengthy question for you. I think you can.
Amit, you can promote Dr. Ajay Khanna as the panelist. So if he can have some comment, he's a senior surgeon from Varanasi.
Done, sir.
Yes,
I have done that. I have done that.
Sanjay, you can take the questions. So
I think most of the questions have been answered during the course of lectures. Madam, there is a case scenario for you in the question answers section. I think you can personally, or should I read it out? Madam came across a patient of COVID. Patient was post-COVID diagnosed with DVT. Patient only had calf pain, no swelling. Doppler 3 centimeter, 60% obliteration lumen at SFV and 1 centimeter in femoral vein, 30% obliterating. D dimer never raised. Patient currently on rivaroxaban 20 mg OD. My question is, in such case, what is the end point of treatment and whether secondary treatment is required? Madam, Gore for you. Hello.
If I'm correct, if I got it correct, patient is on 20 milligrams of rivaroxaban now. Is it?
Yeah.
Yeah.
Yes.
And patient has calf vein thrombosis.
Yes.
Then the treatment duration is
SFV and femoral vein.
pardon me.
It is superficial femoral vein and femoral vein 30% obliterated.
Okay. Then the treatment duration is 3 months because this is particularly a transient risk factor, which is COVID. In fact, most of the patients, no, all of the patients who are admitted with COVID receive anticoagulants as prophylaxis. And they receive it for a period of, the recommended period is at least a duration of 12 weeks. And this person has got the DVT. So the treatment duration for this transient risk factor associated DVT will be 3 months.
Okay.
Dr. Sanjay, if I may add something. See, what is important here is that D dimer was not raised. or D-dimer is not raised, they are saying. Now that is very important because a negative D-dimer
Yes.
goes to tell you that whatever clots or whatever you are seeing could be something old and not necessarily new.
Yeah.
And this is supposed to be post COVID. So when you say post COVID, you need to identify exactly how many days or how many months after COVID we are talking about.
Yes.
And also,
All
when the
those
ultrasound is
clinical
done,
details will be required.
yeah, and when the ultrasound is done, trying to quantify or age the clot would also be important to decide how aggressively one needs to treat. Would you agree, madam?
Yes, that's right.
I agree with your thought that it could be a previous DVT partially recanalized vein, but because D-dimer is negative. But the COVID protocol, as I was reading it, includes if this is a fresh COVID case and not COVID case some 3 months back or last year, then for all COVID patients, the protocol is to give them prophylactic anticoagulation for even after discharge, totally for a period of 12 weeks. So probably this patient having a previous DVT also should get the benefit of doubt and he should receive 3 months of anticoagulation. But then prophylactic dose of rivaroxaban is 10 milligrams and not 20 milligrams.
Yes. Dr. Pai, there is a question for you. Which fiber is used for perforators and the energy settings?
Generally, we use the same fiber that is used for this. We use a 20 gauge Gelco, and you tend to use much lower energy wattage so that you don't end up damaging and causing more and more destruction of the peri-perforator area. Generally, I would tend to use lasers for perforators only if they are really large. That means 8 millimeters and above. If they are smaller, then I'm quite comfortable using just the sclerotherapy with good pressure with my transducer, so that very minimal goes in, and with the calf pump movements that I told you, along with elevation of the limb. You have to be a little careful when you are doing post-thrombotic, because there's a tendency for the sclerosant to accumulate in the deep system, and there you have to be really careful, and you have to warn the patient that look, we are doing this, but there is a possibility of repeat thrombosis.
Just one, not exactly question, a comment, Dr. Paresh. You mentioned about Ulcer X. There are quite a few patients who are in general not comfortable with stockings and not comfortable with Ulcer X also. But those who are comfortable with stockings, I tend to use double compression stockings, grade 2. So it gives significantly higher pressure than using a single stocking or using Ulcer X 2 stockings.
I would agree. I mean, out of maybe 100 patients, only 2 of them end up with Ulcer X. So there are people who are generally very reluctant to come to the clinic, because I have seen that many a times when we use these kind of stockings on the ulcers, the very act of putting it on and removing itself causes repeat ulcer formation. And particularly, a lot of our patients have this funny concept that they will use the stockings after bath. Now, what happens? They get up at 5:30 and 6 and have bath at 9 and 10.
Oh, so 9 is still better. 1 o'clock.
The body comes in. Yeah, but then what happens is the leg is swollen, and when they try to use the stockings or put the stockings on, invariably they keep causing injury, and they end up with newer ulcers. So therefore,
it's a big problem.
I just included that for completeness, but I'm more comfortable with the 4-layer bandages.
Yeah, I don't know what is the experience of you or Shekhar about Circade. Circade cost is quite prohibitive. That is one factor. But I've seen it being used by Dr. Raju, and his patients seem to be happy. Do you have any experience of Circade?
No. Similarly, that new things which have come, which is the wrap.
Yeah.
Compression wraps. again, but they are almost 4 times the cost of one stocking.
Yes, yes.
So somebody who's really desperate to not use stockings, they have
Yeah.
the money, then they go in for the
Agree.
wraps.
Any
Yes,
further questions?
Now I think we are already. Hello. Yes, Niranjan.
Kranti, any comments? Kranti?
Kranti is there. Kranti, there. I think there are 2 more questions. Whether you want to take it by Anjali Davne.
Kranti, unmute yourself.
Okay.
You are muted.
Actually, I would like Dr. Kranti or Dr. Paresh or Dr. Shekhar to comment on use of PCDT or CDT itself and their experience as far as the outcomes are concerned.
Kranti, you want to go first?
You take it, sir. I'll
Okay. See, we've done a lot of cases of this, and we use the cheaper system. But now we've also used a couple of times when we have used the angiojet and we've used the penumbra system. Those really give quick results, but they are very expensive. Each device is 2 lakh rupees plus. And one of the things you said, that there is long hospital stay. Actually, with the way we are doing things, we find that the hospital stay is much, much shorter, if at all they're there. Because what happens is within 24 hours, the whole system gets cleared out. And we start with initially I used to propagate not using an IVC filter. Until 31st December, I had one patient who did very well. And just while we were shifting, patient had a massive pulmonary embolus and died. So since then, I always tend to put a temporary IVC filter coming from the neck, which is parked just below the, in the IVC, just below the renal. Put the patient in the prone position, puncture the popliteal vein, and then start sucking out piece by piece, small amounts. And once we clear the proximals, the distal system, we go more proximally and clear it out. And we establish a channel. Once you have a channel, then you can start giving infusion. Initially, we used to use urokinase, but we found that we prefer to use RTPA. RTPA is a little expensive, but actually, if you start looking at it carefully, you find that you have to give it for a shorter period. It gives you better results. Because with urokinase, you end up giving infusion for maybe 1 day, 2 days, 3 days. Here, you can give it within 6 to 8 hours or even 12 hours. Or the next morning, everything is cleared out and you get good results. And once that is done, then you have to warn the patient that if there is, especially the left side, if after you clear it out and you inject the dye and you find that there is a narrowing in the iliac vein, it's important to treat the narrowing so that you don't get repeat recurrence of thrombosis. And now, initially, the delay used to be for getting the therapeutic INR levels. Now with NOACs, which is there, you can send them home much, much earlier. And because the swelling comes down, you can put them on compression stockings and send them. One more thing I'd like to add is that generally something which I do for all these patients of DVT, especially acute, when they do get admitted, is that we give limb elevation along with compression bandage. So you use Gamgee and then you use crepe bandage, which is removed and reapplied every 12 hours. So once in the morning, once in the evening. With that, you get quick reduction in the swelling. And then you can go on to stockings. And otherwise, what happens is they end up buying a large size. And when the swelling comes down, they have to buy a new pair again, which is a little expensive.
I agree. I hope you are keeping the data so that one day we'll have a paper from you.
Yeah, sure.
If I add more, I think the patient selection is very important here. Right? Not all the patients we should subject to this catheter-directed thrombolysis or pharmacotherapy. I think more important is like when the patient presents to us. If it is within a week, then we get a good result. If it is more than a week, then we tend to get not so good result here. And second thing is the extension of DVT. If it is an ilofemoral DVT, then we should choose those patients rather than any intra-inguinal DVT. So basically, ilofemoral DVT, young patients, these are the good candidates for this format. So, and patient prefers within a week. So these are basically a good subset of patients in whom we should insist on this therapy.
Yeah, I think history also is very important, because if it's an acute and chronic, invariably you don't get good results.
Yes. It should be first episode and within 5 days. That's what is recommended.
Yeah, because the more the delay we tend to get the result. Result is not.
Yeah.
I mean, even there is a rethrombosis, and even the extent of DVT makes a lot of difference. Like if it is a long segment DVT, like right till the IBC and all, then it's basically the duration of the therapy as such, like the sitting wise, or how many times we have to take, the cost wise, everything goes on increasing. At the end of it, we don't get that kind of a result which actually we expect, in spite of spending that kind of a money. So basically, in a cost constraint, the choice of the patient which we subject the patients which for this endovascular therapy, we should be more choosy and careful about to give a good result.
Thank you.
Should we wind up?
Yeah.
Rajesh?
Yeah, thank you all the chairpersons and the speakers. It was a wonderful session. We had a lot of questions also, and it went on quite smooth. I would like to thank our sponsors, Juventus, for giving us the platform and this opportunity. And thank you all the delegates who had appeared in big numbers. I'll hand over to Niranjan to conclude, and then we'll end the program. Dr. Niranjan.
So what we witnessed was some excellent talks today, as expected from the faculties which were invited. Thank you so much. And delegates, just to remind you, this Sunday we have a webinar on safe cholecystectomy session, which will be moderated by Dr. Roy Patankar, and we have Dr. Abhay Dalvi, Dr. Siddesh, Dr. Deep Goyal, Dr. Bapaya as the panelist in that. So please spare your time and log in. The messages are there in the groups, various groups. You can see the registration panel from there. And thank you, Juventus. Thank you, all of you. And we hope whenever we call you again, you'll be there to enlighten our delegates for further CMEs. Thank you so much.
Thank you.
you.
Thank you.
Thank you.
Thank you.
Good night.
So much, sir. Thank you.